Good afternoon, everyone. I am myself Dr. Anushree from Bangalore, India. I am myself a postgraduate student in Department of Obstetrics and Gynecology. Today, I'll be going to present a paper on the study of case causes and outcomes of abdominal pain in pregnancy. Abdominal pain is a common complaint of pregnant patients. Abdominal pain presents with unique clinical challenges during pregnancy. Abdominal pain in pregnancy poses a diagnostic and management challenges to the obstetrician, as many causes are specific to pregnancy, but conditions affecting the non-pregnant woman can also complicate the pregnancy. Causes ranges from obstetric or gynecologic disorders related to pregnancy and also by intra-abdominal diseases incidental to pregnancy. Coming to the natural history and clinical presentation of many abdominal disorders are altered in the pregnancy. Diagnostic evaluation is altered and constrained by pregnancy. There is an issue of fetal safety by radiological testing and invasive examinations. In therapy during pregnancy, interest of both the mother and the fetus must be considered. Anatomical and physiological changes of pregnancy influences the causal identification. Close and vigilant monitoring is necessary when the diagnosis is uncertain, with frequent abdominal examination, regular laboratory tests, which often clarify diagnosis. Multidisciplinary approach should be considered when the diagnosis and symptoms control fail, even after 6 to 8 hours of presentation. Systemic cross-sectional evaluation of the entire abdomen is considered as an important reason for the use of MRI in pregnancy with intractable pain. Appropriate arthroscopic surgery is now proven to be as safe as open surgery in pregnancy. Such condition presenting patterns of non-obstetric causes of the acute abdomen will be helpful in making differential diagnosis and making the plan of investigations to reach the final diagnosis. We aim to identify the precise diagnosis of acute abdomen in pregnant women. Need study. The precise diagnosis of acute abdomen in pregnant women is necessary when it is prolonged, carries a high risk for the both mother and the fetus. All these diagnostic uncertainties causes delay in the decision making, awaiting clear-cut symptoms and signs. Differential diagnosis should be carefully done to take appropriate measures, as so it demands continual updating of abdominal assessment knowledge and clinical skills in the management of abdominal pain in obstetric settings. Coming to the aims and objectives of my study, to study the pattern of abdominal pain in second and third trimester of the pregnancy at ESIC Medical College and PGIMSR Hospital to determine the etiological factors and their outcomes. Materials and it's a retrospective study conducted in the Department of Obstetrics and Gynecology from 2019 to 2020 to assess the causes, presentation, and outcomes of abdominal pain among all gravidas presented with pain abdomen in second and third trimesters. Data collected from the hospital records and medical and surgical notes of patients presented with the pain abdomen who are not in labor. Demographic characteristics, characteristic of the pain, its nature and severity are noted. Medical and surgical history were taken. Inclusion criteria are gravid women presented with pain abdomen second and third trimester. And the exclusion criteria are first trimester causing abortions and pregnancies are excluded. Patients having the true labor pains are excluded in this study. The statistical analysis was done. The data were entered in the Microsoft Excel sheet, proportions was calculated, and the association was tested with chi-square test and Fisher's test. P-value of less than 0.05 is considered as statistically significant. According to my patient age-wide distribution, there were 45% of the patients between 20 to 24 years of age, and 32% were between 25 to 29 years, and 22% between 30 to 34 years, and 1% between 35 to 39 years. And according to gestational age, there were 32% patients with between 15 and 24 period of 24 weeks of gestation, and 47% 25 to 37 weeks of period of gestation, 21% more than 37 weeks. This is represented by the chart I shown here. And according to site of pain, there were more of epigastric and hypogastric pain was involved. That means epigastrium The site of pain was complained by 13% of the patients, and in the hypogastrium, 46%. As you can see, rest are all of 14% with left lumbar and right hypochondrium, right lumbar and iliac fossas, etc. And type and characteristics of the pain. Most of the patients complained of cramping type, which were 41%, and pricking type of 24%, and aching type of 27%. And characteristically, the pain was continuous in 57% of the patients, and it is in 43% of the patients, which is shown in this pie chart. And the findings along with the pain, 27% of the women with the pain were having anemia, and 12% had dehydration, 21% had diabetes, which was included both gestational diabetes and over diabetes, and no patients had jaundice or bleeding. And there were aggravating factors and relieving factors associated with the pain abdomen. But among 70% of the patients, there were no aggravating factors. That is, it was an unexplained pain, and 13% had relation to intake of food, and 1% with the fasting, and 6% with change in the posture. As in the same way, 74% had unexplained relieving factors, and 10% with intake of food and fasting. The causes of the pain, we have divided the causes of the pain according to obstetric causes, gynecological causes, surgical, and medical causes. Among obstetric causes, preterm, about 7% of the patient presentation, and abduction 1%. Gynecological causes like vaginitis were seen in 30% of the patients, and lower urinary tract infection was seen in 90% of the patients. And peptic ulcer disease was seen in 16%, and renal calculus in 11%. Others or surgical causes include acute pyelonephritis, cholecystitis, and appendicitis. Coming to the medical causes, 7% had acute gastroenteritis, and 2% with acute pancreatitis. And this is the chart of distribution of the causes. Management and outcome, we managed all patients in a conservative way, but none of them underwent any diagnostic or therapeutic surgical procedures. Coming to the discussion part, as abdominal pain during pregnancy has unique clinical charges. In our study, about 70% had 94% of the responders did not explain aggravating factors or relieving factors, respectively, and rest of the responders said that food, fasting state, and position changes aggravated pain. Just 73% of them no relieving factors. 79%, 72, 69, and 100% responders had no fever, vomiting, urinary frequency, constipation, vaginal, which is compatible with the same study which was quoted before. And our study found that half the respondents felt pain in the epigastrium and hypochondrium, as it was said in the report form, and cramping and
Well, we will proceed with the next presentation, unfortunately. We're welcoming Halima Al-Balushi from Sultan Qaboos University.
Hello, do you hear me?
Yes, good afternoon. We can hear you now. Thank you.
Good afternoon. Thank you. Can you see my screen?
Yes, thanks.
Okay, so hi everyone. I'm Dr. Halima Al-Balushi from College of Medicine and Health Sciences from Sultan Qaboos University in Sultanate of Oman. And I will present the poster of the undergrad research we have done here in the college, which is entitled Cross-Sectional Study of Congenital Uterine Anomalies in Omani Females. Congenital uterine anomalies is the type of female genital malformation which actually result from abnormal formation or abnormal fusion or abnormal resorption of the Mullerian duct during early process of development in the fetus. And congenital uterine anomalies are considered one of the main reasons for miscarriages and infertility. When it comes to the prevalence of congenital uterine anomalies, there was a study conducted in 2011, and in this study they included about 89,000 women, and they showed that the prevalence of congenital uterine anomalies in infertile women is 8%, and in women with miscarriages and infertility is about 24.5%. In concern with the Gulf region, there was a study conducted in 2016 in the Kingdom of Saudi Arabia, and their findings showed that actually they studied 117 patients, and they showed that about 20% of these patients were having abnormality in the uterus and fallopian tube. And there are so many types of congenital uterine anomalies as it's shown here. There are the didelphys uterus, arcuate uterus, unicornuate uterus, bicornuate uterus, and septate uterus. So our main aim from this study is to estimate the prevalence of congenital uterine anomalies in Omani females and to investigate the most common type of congenital uterine anomalies in Omani females. So what we have done is that we did a cross-sectional study, a retrospective one, and we collected information of subfertile and infertile patients who underwent hysterosalpingogram between January 2013 to December 2018, so in the period of 5 years. And the parameters that we collected from the patient data are the age, type of infertility, presence of congenital uterine anomalies, and the type of the anomaly. We use SPSS to analyze the descriptive data, and we use descriptive statistics and chi-square test to look into the data that we have collected. And when we have a p-value more than 0.05, we consider this as statistically significant data or analysis. This project is approved by the ethics committee in the College of Medicine and Health Sciences here in Oman. So in brief, we included 912 patients who presented for evaluation of primary and secondary infertility. And about 44.5% of the patients included in this study were investigated for primary infertility, and 55.5% of them were investigated for secondary infertility. We found that there is a significant correlation between the age of the patient and the type of infertility under investigation, where the younger age or those who are less than 30 years of age were presented with primary infertility or were investigated for primary infertility, and those who are more than 30 years of age were investigated for or presented with secondary infertility. When it comes to the congenital uterine anomalies, we found that out of 912 patients investigated by hysterosalpingogram, 27 patients were found to have congenital uterine anomalies based on the hysterosalpingogram findings. And this makes the prevalence in this specific population that we have investigated to be 3%. The commonest type of congenital uterine anomalies we found based on the hysterosalpingogram studies is the arcuate uterus, and we don't find any significant correlation between the presence of congenital uterine anomalies and the type of infertility. So in conclusion, the prevalence of congenital uterine anomaly in the Omani female patients investigated for infertility is about 3%. The most common type of congenital uterine anomalies detected is the arcuate uterus, and there is no significant correlation between the type of infertility and the presence of congenital uterine anomalies in the population studied. Uh, in the future, we are actually in the phase of evaluating the fallopian tube anomalies as well. And also we are planning to compare the histosalpingogram finding with the MRI finding. And also in the future, we are planning to see if there is any correlation between presence of congenital uterine anomalies and urinary tract malformation, and also to look into the outcome of the congenital uterine anomalies cases identified in the study in terms of having miscarriages or normal pregnancies and normal deliveries. That's all, and I would like to thank my student Ali Baalawi for all his effort in this study. Thank you very much for your listening, and if there's any question, I'm willing to answer it. Thank you very much.
Well, I believe there are no questions, but still, thank you very much for you and for your student too, for doing and conducting such a research and sharing it with us. Thank you. And now we will continue with Dr. Anushree one more time, as she had disconnected due to technical issues previously.
Okay, can you enable this screen? Yeah. One sec. Can you see my presentation?
Yes, we can see it well.
Yeah, thank you. Yeah. Today I'll be presenting the study of cause and outcomes of the abdominal pain in pregnancy, as I said before, and abdominal pain is the common complaint of pregnant patients. Abdominal pain presents with unique clinical challenges during the pregnancy. Abdominal pain in pregnancy poses a diagnostic and management challenges to the obstetricians. Many causes are specific to pregnancy, but conditions affecting the non-pregnant women can also complicate pregnancy. Causes ranges from obstetric or gynecological disorders related to pregnancy and also by intra-abdominal diseases incidental to pregnancy. Natural history and clinical presentation of many abdominal disorders are altered during pregnancy. The diagnostic evaluation is altered and constrained by pregnancy. There are issues of fetal safety by radiological tests and invasive examinations. In therapy during pregnancy, interests of both mother and the fetus must be considered. Anatomical and physiological changes of pregnancy influences the causal identification. Close and vigilant monitoring is uncertain, with frequent abdominal examination, regular laboratory tests, which often clarify the diagnosis. Multidisciplinary approach should be considered when the diagnosis and symptoms control fail after about 6 to 8 hours. Systematic cross-sectional evaluation of the entire abdomen is considered as an important reason for the use of MRI in pregnancy with intractable pain. An appropriate laparoscopic surgery is now provided to be as safe as open surgery in pregnancy. In such condition, presenting patterns of the non-obstetric causes of the acute abdomen will be helpful in making differential diagnosis and making the plan of investigations to reach the final diagnosis. We aim to identify the precise diagnosis of the acute abdomen in pregnant women. Need for the study being the precise diagnosis of the acute abdomen in pregnant women is necessary when it is prolonged, carries a high risk for both mother and the fetus. All these diagnostic uncertainties causes delay in the decision making, awaiting clear-cut symptoms and signs. Differential diagnosis should be carefully done to take appropriate measures as soon as it demands continual updating of the abdomen, assessment, knowledge, and clinical skills in the management of abdominal pain in obstetric settings. The aims and objectives being to study the pattern of abdominal pain second and third trimester of pregnancy at ESIC and PGIMSR hospital to determine the etiological factors and their outcomes. Materials and methods being that it's a retrospective study conducted in the Department of Obstetrics and Gynecology from 2019 to 2020 to assess the causes, presentation, and outcomes of abdominal pain among all gravidas presented with pain abdomen in second and third trimester. Were collected from the hospital records and medical and surgical notes of patients presented with pain abdomen who are not in labor. Demographic characteristic of pain, its nature and severity are noted. Medical and surgical history were taken. Inclusion criteria being gravid women presented with pain abdomen in second and third trimester, and exclusion criteria being first trimester cause of pain abdomen like abortions and ectopic pregnancy are excluded. Patients having true labor pains were excluded. Statistical analysis was done by entering the data in the Microsoft Excel sheet. Proportion was calculated and the association was tested with chi-square test and Fisher's test. P-value of less than 0.05 is considered as statistically significant. Coming to the results, we distributed our patients according to age-wise. 45% of the women belonged to the age group of 20 to 24 years, 32% were between 25 to 29 years, and 22% were 30 to 34 years, and 1% of women belonged to 35 to 39 years. According to gestational age, there were 32% of the females between 15 to 24 years, and 47% between 25 to 37 years, and 21% were more than 37 weeks of gestation. This is the chart which shows the same gestational age and the age of the patient distribution. And coming to the site of the pain, where epigastrial pain was complained among 13% of the females and hypogastrial pain in 46%, and rest included other sites of the abdominal quadrant like right hypochondrium, lumbar, iliac fossa, and umbilical region. And coming to the type of the pain, there was cramping pain was complained among 41% of the females, and 24% complained breaking type and aching in 27%, and rest being stabbing and throbbing types. Coming to the characteristic of pain, where the continuous pain was seen 57% of the females and periodic pain in 43%. This is the same characteristic of the pain distribution in the pie chart. And associated signs include anemia was seen in 27% of the patients presented with a pain abdomen, and dehydration was seen in 12%, and diabetes was seen in 21%, which included both gestational diabetes and the over diabetes. No jaundice was seen in any patient, and no bleeding per vagina was seen. And other associated factors like there were aggravating and relieving factors where 70% of the patients didn't complain any aggravating factors, and 13% were associated with intake of food, and 1% with fasting, and 6% in change of posture, and 74% had unexplained relieving factors, and 10% with food and fasting status. Causes being, we divided the causes among obstetric, gynecological, surgical, and medical causes. Threatened preterm was seen 7% of the patients, and abruptio placenta in 1%. Gynecological causes being vaginitis in 30% and UTI in 19%. Surgical causes like peptic ulcer disease, which was 16%. Renal calculus was seen in 11%. Other surgical causes being acute pyelonephritis, cholecystitis, and appendicitis. Medical causes are acute gastroenteritis, which was seen in 7% of the cases, and acute pancreatitis in 2%. This is the same pie chart which shows the distribution for causes. Management and outcome. We managed all the patients presented with a pain abdomen who were not in labor conservatively only. We didn't intervene with any diagnostic or therapeutic surgical interventions. Coming to the discussion, abdominal pain during pregnancy presents unique clinical challenges. In our study, about 70% and 74% of the respondents did not explain aggravating or relieving factors, and rest of the respondents said that the food fasting state, positional change aggravated the pain as well as relieved it, which is compatible to study done by Monochrome et al., where 73% of them had no aggravating and relieving factors. Besides, other associated factors like fever, vomiting, urinary frequency, constipation, vaginal bleeding was not seen in most of the patients, which is compatible to the same study which I quoted before, had the same results. Our study found that half of the respondents felt pain in the epigastrium and hypochondrial region, cramping and pricking type, and also the aching type where pain were more, and 57% respondents suffered from continuous type of pain. The present study showed that 70% of symptoms with abdominal pain had vaginitis, peptic ulcer disease, lower urinary tract infection, and renal calculi. Relatable to study done, which is quoted before, where 24%, 10% responded had peptic ulcer and lower urinary tract infection. However, another study showed that it showed ovarians and acute appendicitis were the most commonest pathologies finding, and no abnormality in 26% of the cases, which was where the laparotomy was undertaken for the non-obstetric cause of the pain. And besides acute gastroenteritis, acute pyelonephritis, acute cholecystitis, appendicitis, and acute pancreatitis were rest of the included in the rest of the pain patterns. And there were investigated with hemogram, biochemical analysis, urine analysis, USG for the diagnosis, and also for the fetal assessment. Tocolytic therapy was given for the threatened preterm patients. Emergency cesarean section done for abruptio placenta, and vaginitis treated with the oral metronidazole, and peptic ulcer disease with antacids, and proton pump inhibitors, and UTI and pyelonephritis with antibiotics based on culture sensitivity reports. Cholecystitis, appendicitis, pancreatitis are treated with antibiotics and other supportive measures. No patients underwent invasive procedures or invasive modality of treatment. Both maternal and fetal outcomes were good and uneventful. Note the following diagnostic laparoscopy. Following diagnostic laparoscopy, the risk of precipitating labor was negligible, provided no unnecessary surgical maneuvers were done. And it is claimed that progesterone in pregnancy is responsible for the slowed motility of the GI tract and even the gallbladder, which is responsible for most pain abdomen and the vomiting. Coming to the conclusion, the causes of the abdominal pain in pregnancy is difficult to establish because of many confounding factors. From this study, it is clear that the precise diagnosis of the acute abdominal pregnant woman is necessary. Differential diagnosis should be carefully done to take appropriate measures. USG is the first line of radiological investigation. It is inconclusive. MRI can be used to establish diagnosis. Any delay in diagnosis and treatment may deteriorate the condition of the mother and the fetus or as well. Therefore, timely diagnosis and prompt treatment is the key. The condition demands continual updating of abdominal assessment knowledge and clinical skills in the management of abdominal pain in obstetric settings. These are my references, and thank you. If any questions, I'm here to answer them. Hello, can you hear me?
Yeah, well, just think that there are no questions still. Thank you very much for your presentation.
Thank you. Thank you.
So we will continue with Dr. Luis Angel Bolio Molina from Mexico. He represents as a pediatrician in private practice and will share with us his point of view on neonatal dehydration criteria.